diagnosed with CML is very scary. However, we've come a long way in the treatment of CML, and the successes we have today are the results of hundreds of years of research and work done by some very dedicated scientists. Our special presentation today highlights some important milestones and discoveries on the way to closing in on a cure for CML. It's hard to believe that cancer has been around for so long. In 1500, the Egyptians documented breast tumors and could even tell which ones were malignant or not. Hippocrates coined the term cancer, and he used the word karkinos, which means crab, to describe what it was, because this is what the tumors reminded him of. Ancient philosophers believed in atoms and small molecules that held things together, but we really just didn't have the technology to see them. From the first eyeglasses to the simple microscopes to compound microscopes opening up microbiology, electron microscopes, we can finally see the atoms that have been there all along. Phase contrast microscopes help us to observe living cells and the processes going on inside them, and scanning tunneling microscopes help us to explore our own DNA. But now that we could see, we could delve deeper into the disease and learn more about its origins. With the help of a microscope, we could now see blood and its components, the cells. In 1845 in Scotland, the first case of leukemia was diagnosed. It was noted that the patient had an abnormally high level of white blood cells. The Germans diagnosed two other cases and coined the term leukemia, leuk from white blood cell and hemia from the Latin word for blood. In 1872, leukemic stem cells come from the bone marrow, and by 1913 we have 4 separate classes of leukemia. In 1914, Theodore Bouveri suggests that changes in chromosomes may actually cause leukemia. In 1953, Watson and Crick discovered DNA, and in 1958 we finally all agree that we have 46 chromosomes and not the 48 we had originally thought we had. Just 1 year after the discovery of DNA, an accidental splash of water onto slides containing blood smears of CML patients caused the cells to burst and spill open their chromosomes. Noel and Hungerford analyzed several CML patient specimens and determined an odd chromosome. It was named after the city in which it was discovered, and we know it as the Philadelphia chromosome. The banding technique has greatly improved karyotyping of chromosomes, and in 1973, Janet Rowley had saved tissue samples from all of her CML patients and decided to try this new banding technique. She examined the results while sitting at her dining room table. She was a part-time MD, a mom, and a wife. She discovered the existence of a translocation between chromosomes 9 and 22 in CML. Translocation is the process by which 2 chromosomes exchange material when both break. But Nora Heisterkamp in 1983 worked on proving what Dr. Rowley was claiming all along. In 1982, they still did not know that the translocation was reciprocal, but by March 1983, they had developed the southern blot, and by November of 1983, she had localized c-Abl adjacent to a translocation breakpoint named BCR, which stands for Breakpoint Cluster Region, which described what it did. Owen Witt identified BCR-Abl as a tyrosine kinase. Tyrosine kinases are important in controlling other enzymes. BCR-Abl's structure allowed it to circumvent the usual methods that cells use to regulate tyrosine kinases, leading to uncontrolled cell growth, essentially cancer. Arsenic has been used since the time of Hippocrates, and interestingly enough, we are still using arsenics for some forms of leukemia. Did you realize how old hydroxyurea is? Some of us are still taking it today in the first 2 weeks after diagnosis. Soldiers exposed to mustard gas had low white blood cells, and busulfan is still used as a conditioning agent for BMT. Bone marrow transplant was first performed in 1959. Through the 50s, the work was on perfecting bone marrow transplants and discovering interferons. From 1980 to 2000, most CML patients were being treated with interferons either alone or combined with Ara-C. But we were not winning the war, and we were not even winning the battle. Work by Dr. Levitsky on trifostines led Drs. Leiden, Drucker, and Sawyers to a molecule at Novartis that was originally designed to treat glioblastomas. Jörg Zimmermann, working with Elisabeth Buchstanger, altered the molecule, and Dr. Drucker tested it and found that this would work. The molecule was STI-571, STI for signal transduction inhibitor, but we know it now as Gleevec. Gleevec is a story of great discoveries backed by patient activism. As with all drug clinical trials, the first patients to access it were very sick. However, the phase 1 dose escalating trials showed that with just a small dose, some patients could get up from their hospital beds and go home. Once all patients had their doses escalated to close to 300 milligrams per day, most patients achieved a cytogenetic response. And thanks to some early patient advocates like Peter Robotham, everyone had heard about it through the internet, and they were desperate to access STI-571 as it was called then. By January 2000, Novartis had provided expanded access for hundreds of patients after an online petition led by Susan McNamara, and happily this soon grew to thousands. The news about Gleevec at the American Society of Hematology meeting in December of 2000 made headlines. I even recall hearing about it on NBC Nightly News with Tom Brokaw, and I was quite amazed, as I had just been diagnosed with CML 2 weeks prior to this exciting news. Gleevec has changed the history of CML. Lives have been prolonged. There were 2,300 deaths in 1997, and this has decreased to approximately 600 deaths in 2006 in the US, while the incidence of the disease has remained stable. In 2011, we now know that there are about 500 deaths a year in the US, and there are about 50 deaths here in Canada. The success of Gleevec stimulated new research in CML. We now can combine Gleevec with other TKIs or other newer drugs like hedgehog inhibitors or JAK2, or even with older drugs like Xylutin and hydroxychloroquine. Importantly, the newer drugs such as Sprycel and Tasigna help patients achieve MMR and in particular CMR, which is improving progression-free survival and overall survival. We now have a wide range of drugs to help us achieve better responses: imatinib, dasatinib, nilotinib, bosutinib, panatinib, and omacedoxine. The right drug for the right dose at the right time, and now with new upfront gene testing such as looking for the KRDS1 gene and CYP2A, or counting the amount of leukemic stem cells in bone marrow biopsies, physicians can guide us to the right drug at the right dose up front. Just 4 years after the launch of Gleevec on the market, several patients in Europe stopped taking the drug without signs of disease recurrence. By 2011, Dr. Francois Mahone has reported success with nilotinib and dasatinib in patients who were resistant or intolerant to Gleevec. And he reminds us all, if you want to stop taking the drug, you have to take the drug. The research continues. If you just do a quick search of the clinicaltrials.gov website for CML trials, you will see a long list of trials where the word cure is not such a foreign concept. Also, you can visit our website at www.cmlsociety.org for a list of Canadian trials. CML in Canada affects 1 in 100,000, and we estimate that there are about 4,500 Canadians living with this disease. 450 Canadians will be diagnosed with CML this year, and unfortunately 50 Canadians will die. Usually CML affects people in midlife, but we feel we are now seeing earlier incidences of CML. So how did CML Awareness Day come about? It started at a patient advisory board meeting at the CML Society of Canada. So we basically thought about the 9th month being September, and the 22nd day represents the 9/22 translocation, which is the harbinger of CML.
Mr. Speaker, tomorrow is CML Awareness Day, and I'm honored to host a lunch briefing here in Ottawa to celebrate the great progress being made to control CML. CML is a slowly progressing cancer of the blood and bone marrow. It is the first cancer for which scientists were able to identify the genetic anomaly involved, and that is the Philadelphia chromosome. This discovery has led to the development of the first targeted cancer therapy. While these therapies are highly effective, they are not a cure and very expensive. Additionally, some patients still require regular blood transfusions and bone marrow transplants. Further stem cell research is vital to fighting this disease. I would like to recognize the work of the CML Society of Canada, a not-for-profit organization that provides invaluable support, education, and information to patients and families. We need to remember that more work is needed to ensure all cancer patients have access to the best treatments and services available.
We are well on the way to a cure, but we have a few more obstacles to overcome. We believe that every patient deserves to get the right drug at the right dose at the right time. We believe that equitable access to essential drugs is an inalienable right for all Canadians. We believe that our best chance for a cure is through partnering with our physicians, government, and industry. And we believe that it's nothing about us without us. The cure is close at hand. Imagine what the introductory page to our website would say. There once was an insidious disease called chronic myelogenous leukemia, and this is how we cured it. Help us put ourselves out of business, even if we're not for profit anyway.